Hi again, and welcome to day 2 of the Global Health Reciprocal Innovation Workshop. Next slide, please. Before I go over the agenda for today, I have to admit that I reviewed all the videos from yesterday's breakouts and presentations, and panel presentations, and they were truly spectacular. Next slide, please. Don't those people look happy as they're working so hard? Using the examples from our panelists and adding their own experiences, the groups, led by amazing facilitators, thoughtfully discussed our mandate for the day, which was to address GHRI research models, barriers, and opportunities. Here, I've listed just a few of the very many ideas for various models, barriers, and opportunities that were suggested through the discussions and the presentations. And I am chomping at the bit to see and hear the presentations and discussions today. Next slide, please. Today, we will have 2 panels. Panel 2 presentations will be on GHRI methods, frameworks, research gaps. And panel 3 presentations will be on equity issues and laws affecting GHRI research. The setup will be similar to yesterday, with the panel presentations first, then a short Q&A followed by breakout sessions and a short report out. I'm emphasizing the short because we will have a bit less time today for the Q&A, the breakouts, and the report outs because we have 2 panels instead of 1. As you did yesterday, please put your questions in the chat and take a short break at the start of the breakout sessions if you wish. Please consult the bios you were sent for more details about presenters, moderators, facilitators, and note takers. And please note, these sessions are all being recorded. I will now like to introduce the moderators of today's session. Panel 2 will be moderated by Chandi John. Chandi is the director of the Ryan White Center for Pediatric Infectious Disease and Global Health at Indiana University. And panel 3 will be moderated by Jen Cates. Jen is the Senior Vice President and Director of Global Health and HIV Policy at the Kaiser Family Foundation. Both Chandi and Jen are members of Fogarty's advisory board. Chandi, over to you.
Thanks, Linda. I'm looking forward to today's presentations. Just as a matter of housekeeping, I mentioned speakers before. I'll give you a 9-minute warning since we're on a fairly tight schedule. I was here for most of yesterday's presentations, and like Linda, I found them really informative and enlightening. And I think what's interesting is the kind of range of opportunities there are, which will be exemplified in this session's talks as well. So without further ado, I will turn the floor over to our first speaker, Susan Zeeth from San Francisco State University.
Good morning. Thank you, everyone. Thank you for this invitation and the inclusion of the Open Streets Initiative into the discussion of global health reciprocal innovation. Next slide, please. So if you're not familiar with the Open Streets, they're a global initiative, and we often give Bogota, Colombia, the claim as the first to initiate this in the 1970s. And the basic program is to open a route of city streets to recreational activity by closing them to motorized vehicles. We were an early adopter of this initiative in San Francisco following a presentation by the Bogota Recreation Director in 2008. Typically, the open streets have multiple goals, but typical among them is community building and recreational activity. And there's the less explicit goal of climate action. So these are multifaceted types of initiatives. In San Francisco, the initiative was top down, from the mayor to a collaboration between public health and the Municipal Transportation Authority, and eventually it was handed off to its own nonprofit called Sunday Streets SF. Its current home is with another nonprofit organization, Livable City, giving it a more transportation orientation. The role of the mayor and this idea of political will and the public-private model makes San Francisco somewhat unique among open streets initiatives. The mayor's goal was explicitly community building, and the first route connected two very diverse neighborhoods quite purposely. And these were a historical Chinese-American neighborhood and historical African-American neighborhood. But the involvement of the public health department early on meant that health benefits were also at the forefront. It was clearly going to be a large-scale event with community involvement. And you see here that in Bogota, it is one of the largest in the world, about 120 kilometers of city streets. You're reading that right, about 80 miles, and difficult to count, but many, many attendees every single Sunday for that 7-hour period. San Francisco's is a bit different. We've got from 8,000 to 25,000 participants, and they meet from 11 a.m. to 4 p.m. one Sunday a month. And this idea of sort of frequency was an issue around what the potential benefits would be. We solved that in some ways by looking at where people were coming from, and we found that people did attend from all over the city. And in addition, one of our very important outcomes, I'll just jump to for a moment now, is that people were motivated and actually changed their health behavior as a result of attending Sunday Streets. We had about a 24% behavior change. In a meeting with the CDC physical activity branch chief in about 2012, at the beginning of our evaluative work, we discussed the importance of meeting the physical activity guidelines in one dose, in one event on a month or in a week. And he said at that time that that was considered acceptable. And that's certainly an interesting point to discuss further. Slide number 3, please, or next slide. Thank you. So outlined here are the main structures of the work done by Sunday Streets and that of others we found that were necessary to establish this initiative. And some outcomes from Sunday Streets impacted communities more broadly and had sustainable effects. And just very briefly here, we note that the very important piece about connecting with the neighborhoods and getting buy-in, of course, important to many different types of interventions. There are such broad-ranging differences between neighborhoods. We learned about faith communities and their needs. We learned about merchant needs. And in fact, we did conduct a business impact assessment. So along the way of discovery, we figured out different kinds of ways that, or elements that were needed by each of these different routes. Planning the route, we very much focused on commercial corridors, least impacting transit served streets, and very importantly to the San Francisco model was the way that the routes were planned, where it was by using an overlay of chronic disease maps, low resource neighborhoods, ethnic minority populations, and clearly those with less access to healthy spaces. And just as a side note here, the San Francisco model also is a rotating selection of routes. We do not use the same route every time, and therefore we get as much reach as possible. Clearly, that's still an issue that needs more work. We have mostly a volunteer model. This is also about buy-in from the local neighborhoods. Many of the volunteers come from the neighborhoods and are able to leverage this into sometimes either temporary, part-time, or more full-time work. We had in-kind marketing from a local newspaper, which included the route map. I'll show you in just a few moments. Operations and permitting, probably one of the biggest complications. Just as another side note here, we found that some city policies were impacted by Sunday Streets in a positive direction. The police and public safety monitors were initially charging double and a half overtime. And you can imagine that for a nonprofit that was challenging. And eventually they changed their policies to include Sunday Streets as part of how they scheduled their employees. And of course, evaluation. We have evaluated in multiple directions around community building, around, as I mentioned, merchant impact, route selection, and most importantly for us, physical activity and health outcomes. Next slide, please. I'm just going to, oh, please, yes, next one. In fact, you can add, please, yeah, continue through. Thank you so much, Irina. I'm going to weigh in just a moment on route selection. Oops, yeah, that happens to me too, which is the key to our San Francisco success and the effectiveness of the initiative. We highlighted social justice goals in the mapping process. And that you can see here, especially around number 2, we wanted to have routes that were served by bike-ready transit, creating open space in communities that are park poor. And if we go down to those bulleted points, we see here that there were multiple different mapping strategies to make sure that we identified neighborhoods with the most need around access to safe and free open space elements. Next slide, please. This is just a working map on the left of what it looked like. And if you went to the Sunday Streets office, you would see literally a map on the wall with all sorts of highlighter over it, which was a very hands-on kind of approach. In the breakout room, we can talk a bit more about partnerships with neighborhoods and programming. The map on the right is what the public saw. That was the free route. And I think I didn't mention that the routes are somewhere between 1.5 miles to 6 miles long. That's an important piece around meeting physical activity goals. And if possible, most of the routes were stationed near other kinds of resources. You can see right in the middle here, the Mission Playground is a very, very small space in this impacted neighborhood. And so the route was connected there. Next slide, please. So working towards sustainability, both benefits and barriers were readily apparent. The need to have buy-in from community partners. We have one major example, well, 2 really, where community partners were a challenging issue in certain neighborhoods. In one, for example, in Chinatown, the merchants did not want this initiative in there because on a Sunday they have a lot of people coming from other parts of the city to shop in that area, and they believe that not being able to park and drive in there would be a real limitation. Hence the need to have a business impact assessment conducted, which we did, and found very positive benefits. And in fact, so positive that after that report was released, other neighborhoods were clamoring for this initiative. So we know that there's some great successes going on here. It is scalable, as I've just mentioned, to other neighborhoods. One of the important points of bringing this from Bogota to smaller size American cities, I think, of course, is this idea about the route selection and how we partner with local neighborhoods in deciding where Sunday Streets is actually going to be held. Clearly, some neighborhoods are more empowered to have this kind of initiative, and how do we educate other communities to advocate for themselves and their neighbors for this kind of benefit, which is both community level in terms of cohesion building and engagement and the public health outcomes. We learned a great deal about distinctions between communities by these different health outcomes and are able to weigh in on those neighborhoods and communities that have lower public health kinds of outcomes. We learned that political will only takes it so far before the communities need to become involved. And again, that sort of education kind of piece. And volunteers became a really important component of the successful initiative. On these Sundays, once a month for 10 to 11 months a year, roughly 300 volunteers help make this happen. So this is an extremely low cost initiative as well. We did conduct a study in conjunction with some of our South American partners who have zero costs on their end. We were around $2 a person and change, still fairly inexpensive compared to other kinds of interventions for the kinds of outcomes that we can hope to have here. Next slide, please. And continue on, Rena, thank you so much. So some of the, So again, some of the benefits and barriers, we found that working with neighborhoods and communities to kind of implement this initiative was challenging. We have a very complicated permitting process, which was since reduced in terms of complexity and timing. We found that route selection clearly was key, and we have to finalize these and announce the routes as soon as possible. And this is also not only to build community and organizational support, but also to minimize impact on neighborhoods where people can suddenly not drive down the street to get home and things like that. We have, of course, had to make that happen. mentioning about routes with key destinations. Longer routes and hours increase the reach. And this was one of the sort of interesting and contentious points around developing these initiatives. How long should it be to actually have public health outcomes and community benefits? And promotion was very necessary for success. And as I mentioned, with tens of thousands of people showing up, and sometimes we have to, there's just too many people, you can hardly even move on the streets. I take that as a great sign of success. Slide, please. And finally, some of the research gaps. We've been finding all over the US that people who are already active love Sunday streets and love open streets. And of course, the key is always how to get people who are not active out to join. This is one of the main reasons why we move this initiative around, so that people can literally walk outside their front door into the event. We did, in many of our studies, we did both quantitative and anecdotal and interview. We have data showing that people actually changed their behavior. They started walking or biking to work once they found out really how simple and close they were. We're a very small physical city. We're 7 square miles, and you can literally walk anywhere if you realize that. We had some unanticipated and indirect outcomes of the intervention. Those were largely along the business lines, noting what was the difference between businesses that were specifically on the route or directly on the route and those that were off of the route. And we have been doing follow-up research that showed actually sustainability of both physical and mental health. Outcomes, I should add in there social outcomes. People found their neighborhoods more safe, more welcoming. They felt more connected to their neighbors and could rely on them in case of need. One of the main barriers to engagement is how people get to Sunday streets. We have quite a bit of public transit in San Francisco, but it is not low cost. And so that can be quite a burden for lower income families. In the very first year of the initiative, Mayor Newsom, well, mayor at that time, now Governor Newsom, required that the Municipal Transportation Agency provide free transportation. And that was clearly a very important piece to the success of this initiative. One of the important opportunities that we discovered was our capacity to work
Susan,
with other.
We will need to wrap up. We're over time now.
Thank you. Was to work with other communities in developing their interventions and who were able to learn from our lessons. Thank you very much.
Thank you very much, Susan. That's a fascinating initiative, and I think many of us would love to see something like that in the cities where we live. So thank you for that information. And we will move on to the next speaker, James Deering from Michigan State University.
Chandy, thank you very much. My name is Jim Deering. I'm in the Department of Communication at Michigan State in East Lansing, Michigan. Thanks also to Linda Kupfer and the Fogarty International Center for inviting me to speak with you today. I want to briefly describe a study that was generously funded by the Robert Wood Johnson Foundation and their global team. The objective of this particular study was rather simple, to draft an evidence-based framework drawing on literatures from the international diffusion of innovations and also scaling up literatures, also drawing on literatures from business and marketing and management, as well as literatures in global health. So drawing on literatures to develop an evidence-based framework. Secondly, to identify innovations for case studies so that we could conduct a comparative case study analysis. And third, to simply use those case studies as a means to test essentially the goodness of fit of the framework to the data. Next slide, please. We had a team with researchers who were from South Korea and Kenya, Haiti, Pakistan, and the US. Next slide. This is the framework that we developed in our project based on the literature review. It really emphasizes the role of especially what we refer to as scale-up strategies, that is, different pathways or means by which an innovation in one country can successfully bridge to other countries. Secondly, partnerships, the interorganizational relations that are brokered so that an innovation can move with the help of those organizations from country to country. And third, issues related to fidelity and especially adaptation or responsible adaptation to new cultural contexts. As you can see, there's a number of variables here. We were coding for each of these variables in a set of interviews that we conducted that then formed the basis for our thematic analysis in the comparative case study we did. Next slide, please. We had selection or inclusion criteria that the innovations we wanted had to be of international origin. They had to have spread to multiple other countries. They needed to be so-called pro-social health innovations. They needed to have process or ideally outcome, sometimes impact data available for us. And then they needed to have evidence of spread to the US, that they were already in the US and being demonstrated or used in US communities. Next slide, please. We had 40 candidate innovations starting out. We reduced that number through a series of decisions down to 5. I'll describe those 5 now. Next slide, Arena. These were the Swedish Rheumatology Quality Registry. This was and still is an initiative to enable both patients and their healthcare providers to input and share data online. Secondly, the Cardiff Violence Prevention Model, which is a way for law enforcement agencies, ER, hospital staff, and community businesses to partner together to reduce violence. Third, Age Well Global from South Africa, which is a means of elder care coordination using both mobile technology and especially social engagement among elders to help other elders. Fourth, Ciclovia, which Susan just described in detail, also called Open Streets in the US. And fifth, Consejo Sano, which is a private firm in Mexico that has been doing business in the US to bring cultural appropriateness and sensitivity to the healthcare outreach efforts, the communication efforts of healthcare systems so that they can enroll and attract poor and disadvantaged community members, Latinas and Latinos especially. Next slide, please. The results of the comparative case study analysis we did showed several things. I'll just mention a few here. There was a clear importance, according to interviewees, in what we call innovation attributes, or you can think of simply as the evidence-based characteristics of new ideas or practices or programs or technologies and how people perceive them as related to the decisions they then make about whether they should try that innovation or not. And then other types of issues like linking agents, the people and organizations that act as bridges between home countries and other countries where innovations are going to be subsequently implemented. Key roles for partnerships, key roles for types of scaling approaches, that is, pathways chosen by social entrepreneurs. Let me sum up by 3 points here about our results. First of all, our study, which was very much like a larger study we did of 45 US-based social entrepreneurs who also had successfully scaled up their social innovations, we saw a need for accessible web-based resources so that there would be less trial and error by social entrepreneurs and their organizations. We found a lot of time wasted, a lot of lessons learned, but a lot of time used up, with the point then being that the work of social entrepreneurs, as they told us, could be much more efficient if they had better advice and information going in to their scale-up activities. Secondly, several key decisions in scale-up strategy are being overlooked by social entrepreneurs in low and middle income countries in particular. And what I mean is that where the trial and error came into play with these social entrepreneurs we interviewed was that they knew about some issues and aspects of their work that were going to be important for scale up and spread and reciprocal innovations getting to the US. But then there were other important considerations that they did not know that are important for diffusion or spread. These also could help them in their forthcoming efforts. And so another way to say that is that there is also a need for sharing evidence-based ideas and concepts that there is good data about, so that these entrepreneurs could do their work more efficiently and effectively. Lastly, because there are so many worthy innovations in low and middle income countries, the real test of whether they can benefit segments of the US population happens in the US, in US communities, which is, we see it as a demand side logic rather than a supply side issue. What this really means to us is that helping social entrepreneurs in low and middle income countries and their linking agents in the US needs to occur through a process of responsible, or what we refer to as guided adaptation of their innovations into US communities. Thank you very much.
Thanks, Jim. Well on time. And I think this was a wonderful talk to have, because it sort of sets the stage for all the other talks and how these things can be implemented. So thank you for that. And we move on to our next speaker, Yolanda Bulu from University of Maryland. Welcome, Yolanda.
Hi, good morning, everyone. I'm Yolanda Obulu. I co-direct, along with Virginia Rawthorne, who's on the call, the Global Learning for Health Equity Network at University of Maryland. We use the term global learning, so I want to just quickly define that. Global learning for health equity is the practice of engaging with, exchanging, and adapting health equity, promoting ideas and interventions between communities. We do that in a way that fosters implementation benefits that are reciprocal and beneficial to both communities. Global learning, as was discussed yesterday, is similar to reciprocal innovation in that it is bidirectional. However, it acknowledges that achieving reciprocal innovation really requires a commitment to a continuous learning process. Next slide. We believe that despite much effort right now to work in the health equity space, that we have a long way to go to really improve global population health. That no country has a monopoly on ideas, and that we have great minds everywhere. I've been privileged to work in both global health and health equity space, and help to see health equity advance in my lifetime. We know that to achieve these goals, we need to build a larger toolkit. We see global innovation, global health, reciprocal innovation, and global learning as one piece of this puzzle. Next slide, please. The Global Learning to Advance Health Equity Network was established in 2020. University of Maryland, Baltimore is the hub for the network, but works in close collaboration with national partners from Athens County City Health Department, the COPE program in the Four Corners of the region in the Navajo Nation, in collaboration with Brigham and Women's Hospital, Albert Einstein School of Medicine and Montefiore Health System, and Henry Ford Health System and the Corner Health System in Michigan. The network started with these 5 communities. We really wanted to look at people that have been working in the global learning space, but also do it in a way that we went across diverse populations. So we worked in 3 urban settings in the Bronx, New York, Detroit, and Baltimore, and 2 rural settings in Athens, Ohio, and Navajo Nation. Examples of the global ideas that our experts have implemented are here, and they include adaptation and implementation of community health work models from Togo to the Bronx, social participation models from Latin America to Ohio, social inclusion models from Brazil to Baltimore, child development and nutrition programs from Peru to the Navajo Nation, and health system improvements from Nepal and Rwanda to Detroit. Over the past 2 years, our network completed a Scope Broadly and Reflect Deeply stage and held multiple webinar series and recently published a review of the literature. From our landscape analysis, discussions, we understand that the practice of global learning is newly emerging. It's often being implemented with limited systematic approaches and guidance. To support the expansion of global learning, next slide, our team created a global learning for health equity framework, which is a graphic representation of the global learning process. We wanted to create this graphic framework to really make global learning engaging and more accessible, not only for newcomers, but also to help experienced global learning experts expand their work. The center of the global learning for health equity model reflects the core values of global learning for health equity. The domains around the edge of the model represent 11 different dimensions of global learning, from impact to share. While the model is a cycle, we know that the process is iterative. Communities, researchers, and health equity promoters have stepped into global learning at different stages and proceed through the dimensions in the model in different orders. Thus, the dimensions of the framework are multi-directional and may have intersectionality with one another. In the next few slides, I'll explain this graphic in a little bit more detail. Next slide. First, our work is guided by core values and principles of global learning for health equity. We think this is critically important to our work because without these core values at the center of our work, we believe that the process of implementing global innovations has the potential to be extractive or appropriative, thereby reproducing historic inequities in the diffusion of knowledge. At one of our webinars, we asked participants to describe global learning, and we were really excited to see that it was a value-based response. Participants highlighted humility, collaboration, equity, and the need to have anti-colonial and anti-racist approaches. From this activity and many others, we identified trust, respect, humility, and reciprocity as the center of our global learning network. Next, I'll go quickly through the 11 domains that are on the outer circle of the framework. Next slide. While researchers can believe at any begin the cycle at any point on the continuum, we believe that considering the public health impact to your community is a good first step. It's essential that global learning is considered in relation to an articulated health equity challenge from the community, and that there's community agreement on desired health equity outcomes. If this discernment does not happen, we think that there's less likely to be community uptake of the initiative and that the initiative is less likely to be sustained over time. The next two phases are explore and identify. In the explore phase, we know that individuals can learn about different approaches that are around the world that really align with that critical issue that they hope to address. And then they can identify solutions. These solutions can be identified from a number of ways: through database review, through travel or direct exposure to a global initiatives, or through a pre-implementation evaluation. One of the most important things that we've learned in terms of being able to begin the adaptation process for a global innovation is to really think about how to contextualize the innovation as we think about implementing it in a different setting. This requires that we ask a critical question of what cultural, historical, political, and economic context were the global idea found, and how might that be similar in the place where you're trying to implement it. We know that communities that share similar challenges of systemic barriers and burdens, including colonization and discrimination, may have similar solutions. From the after contextualizing to really prepare for adaptation, global learners enter into the examine and adapt phase. Next slide.
1 minute left.
Okay, sure. So as we think about the final phases within our model, we know that collaboration, ideally bidirectional collaboration, should occur across all domains, but we thought it was important to list it within the model to reinforce the need for bidirectional learning. We also found that it's critical for global learners to think about and plan what components of the global idea will the community adopt. This was a question that was raised yesterday. What are the core components? What are the barriers and facilitators to uptake? And what partnerships are important? We use that information to really adapt and customize the idea to address the unique health equity needs of communities. In doing so, we found that using implementation science is a really critical component that allows us to adapt and understand how to increase uptake of a global idea. Measuring is also critically important. Thinking about how will your community measure progress towards its desired health equity outcomes. Both global learning and GHRI are well positioned to address a variety of health equity outcomes. And within our literature review, we have a long list of health equity outcomes that have been studied, from social participation in health to disparities in HIV outcomes. Finally, sharing the information. Thinking about how will the insights be shared back to the community, also to those who have inspired its effort and others seeking solutions. From the literature review, we know that dissemination of learnings has been quite limited. Expanded research is needed to understand how those who have engaged in global learning translate knowledge to communities impacted by inequities. Okay, next slide. That was a quick tour of our graphic and our framework. Next steps are to make the framework multidimensional with training tools and resources embedded. We hope that the model will be used as a pragmatic guide to help researchers, global health leaders, and health equity practitioners engage in global learning. We will also test the model this coming year through small innovation grants. Thank you, and thank you to Robert Wood Johnson Foundation for funding our network. Please feel free to snap the QR code so that you can learn more about our framework and our network.
Thanks very much, Yolanda, for that excellent talk, and it pairs very well, I think, with the prior talk in terms of thinking about a framework for doing reciprocal innovation, and I believe with the next talk by Jonathan Sugarman. So welcome, Dr. Sugarman.
Thank you, Chandy. And yes, I think it will link very nicely to this presentation as well. And also thanks, Linda, for inviting me to share this work. So in the next 10 minutes, I'll be discussing a resource called Global Learning for U.S. Primary Healthcare, as shown in the title of this slide. And I'd like to address 3 topics. First, I'll provide a bit of context for the project and the organization from which it arose. Then I'll describe a resource and implementation guide that's really intended to support individuals and organizations who are open to the application of global learning. And I'll briefly outline the contents of the guide. Finally, I'll summarize one of the key elements of the guide, which is a framework describing actions that can support global learning at various points on the continuum, or as Yolanda described it, a spectrum. Before I begin, though, I want to acknowledge that the primary focus of this work is application of ideas from abroad in the US, and not so much on reciprocity or bidirectionality. Thus, it might not really fit under the definition of reciprocal innovation that was introduced yesterday. That said, I think it still may be of some use in the context of reciprocal innovation. Next slide, please, Arena. So this work had its beginnings with a small nonprofit organization called Global to Local, which was established about 12 years ago with a somewhat unique orientation and commitment to global learning that I think distinguishes it from most domestic health and healthcare organizations. In 2010, the organization was founded by some thoughtful representatives of several Seattle-based global health and public health organizations, Washington Global Health Alliance, PATH, the County Health Department, a multi-site community health center called Health Point, and Swedish, which is a large local health system. As you know, Seattle's the home to many global health organizations, Gates Foundation, PATH, Institute for Health Metrics and Evaluation, the University of Washington, Department of Global Health. The founders of Global to Local reasoned that their global health expertise could be leveraged to improve health and health equity here, particularly for vulnerable and underserved communities. They recognize, of course, the existence of very large health disparities within King County. That's the county in which Seattle is located, particularly in the southern part of the county. So Global to Local began working in the cities of SeaTac and Tukwila, which are very diverse communities. Over 70 languages are spoken in the public schools. Half the population are not native born and half speak a language other than English in their home. In order to identify a place to start their work based on global health expertise, looking at various data sets, they found fairly low immunization rates in the community and wondered whether experience in global health immunization programs could be applied here. Turns out, though, that idea was not greeted with great enthusiasm by the community stakeholders. So they spent about a year talking with members of the community and asking a question: what makes it hard for people in this community to be healthy? And they responded with things like poor access to healthy foods, limited opportunities to exercise, poor economic opportunity, lack of a seat at civic tables, and similar challenges. Next slide, please. So how did Global to Local apply lessons from global health to address those challenges? Well, the first thing they did was commission a report from PATH, a landscape analysis, to identify global health strategies that could be potentially transferable to the US. The assessment was first done in 2010. It was updated in 2017. It identified 11 strategies, 7 of which are shown on this slide. Now, none of these strategies are particularly unique to other countries, but the emphasis placed on them and the ways in which they're prioritized might be instructive to those of us in the US who are striving to overcome challenges to public health or healthcare delivery. The topic of this presentation is not really Global to Local's work, but I'll just quickly say that based on these, the organization developed a number of programs, community health worker programs, programs to support food entrepreneurs and developing businesses, culturally acceptable exercise programs, and others that were kind of generally modeled and inspired by some of these global health strategies. Next slide. In 2019, the Commonwealth Fund awarded a grant to Global Local to prepare some materials that could help guide other organizations to apply global learning and improve primary health care in the US. In addition to describing the work that Global Health had done, that Global to Local had done, the project harvested information from other organizations across the country who'd been working in the same area. We established an expert panel, a couple of members of which are actually on this panel, to advise us as well, and developed an implementation guide that had several components. First, we proposed a framework, which I'll describe in a minute, for the application of global learning to the US, and included a number of case examples related to the framework. Second, we developed a reflection tool intended to help organizations assess their readiness and capacity to apply global learning. And third, we provided a series of activities to consider in order to support implementation of global learning. Now, the target audience for this work was not experts in global health, academics or researchers. It was primarily intended to help organizations such as community health centers and organized health systems think about application of global learning and provide a bit of a roadmap to guide progress in implementing it. So for the remainder of our time, just a few minutes, I'll focus on the framework, a schematic of which is shown here. It includes 3 primary domains or stages, each of which includes 2 focus areas, and I'll quickly review them in the next couple of slides. So next slide, Irina. The first stage focuses on incorporation of a global perspective. Although he didn't mention it in this talk, Jim Deering has many times said that there is no paucity of great global ideas. This is a demand issue in many ways, not a supply issue. So the first part of the model here focuses on helping organizations understand both why it's important to focus on ideas from abroad and how to do that. We actually think there's several ways to do it. If you could click the first button, Arena. Much of what we've heard over the past couple of days has been related to replication, adoption, or adaptation of specific programs or interventions. An example we'll hear about later is the Friendship Bench, but many of the programs like the Ciclovia example we just heard are specific interventions. Next button though. But there are other ways that can range from just general inspiration. So for example, the Community Health Equity Program, Community Partnerships for Health Equity Program, MEDIC, for years has taken groups from communities to Cuba to look at their health system, which is obviously much different from ours, but to really inspire people to come back and generally implement programs that are not dissimilar. And we share some examples of that in the resource guide. And the next button talks about general health strategy. So yesterday, Deborah Litzelman mentioned the importance of community health workers, which are clearly used across the United States, but they are core to the health systems in many countries. And a number of groups have really relied on community health worker examples from other countries. So inspiration and strategies in addition to specific programs are important things. Next slide. The guide, and I'll quickly go through the next couple of slides. The next stage of the guide focuses on, first of all, on global approaches to community engagement. The reason for that is this particular project was focused on primary health care as defined by the World Health Organization, which is different from just primary care, healthcare delivery. It also includes multi-sectoral advocacy and action and focuses on community empowerment engagement. So there are a number of resources related to that. We talk a little bit about how to identify, thanks, Chandy. We talk about ways in which one can identify global health ideas and include a number of resources that help do that. Next slide. And finally, we have some resources that are really intended to alert these organizations, who again are not primarily researchers and experts in global health, to learn a little bit about the technical aspects of transferring interventions or ideas from one site to another, and point them to resources such as those that Jim Deering just described, are related to implementation science, diffusion of innovation theory, and a variety of related activities. Given that the time is about to end, I'll stop there. That's the last slide, and perhaps we can address some of these. I've talked pretty quickly in the question and answer series or in the breakout sessions. I think I did it under 10 minutes, Chandy.
Yep, you did right at 10 minutes, so excellent. We had a couple questions in the chat. If people have other questions, they can put them in now, but we're getting close to time. We had a couple questions for Susan that she answered within the chat. I will, since I don't see other questions, I will maybe just wrap things up, ask our three last presenters who presented these frameworks, how they think that we can use this both in the papers to be written and for the, like, what's a practical outcome of this in terms of people getting this information and applying it to their potential reciprocal innovation projects. And maybe I'll start with Dr. Obulu.
Sure. So thank you. The Global Learning for Health Equity Network actually welcomes this. We will be having implementation planning grants offered soon that will encourage people to use this framework. The framework was really designed to be a quick graphic where people can look, and it can really help people that are new to it or people that are really experiencing global learning, but need to have more of a systematic approach. So we welcome, and we'll share the slides and welcome others to be in touch with us about the framework.
Thank you very much. And Dr. Deering.
We have created a report around this framework, standard kind of thing, and published an article recently in the Annals of Global Health. But more importantly, really, I think is outreach to practitioners and to social entrepreneurs. And I think that some networks, like the one that Yolanda has referred to, are critically important if practitioners are members of those networks. So not just academics, but folks who are doing this and trying things out in the field. So I would hope that in time, there would be funding agencies that would develop sharing systems or support the development of communities of practice focused on the issue of the challenges of scale up and moving country to country for entrepreneurs in low and middle income countries, as well as for the potential adopters in US communities again.
Thanks, Jim. And Jonathan, last word.
So I would echo what Jim said. I do think that this is in many ways a demand rather than a supply problem. There are lots of ideas. There are methods to implement global learning. But looking abroad is certainly not the only and certainly not the first and not the only thing that people think of when they're trying to address problems. So any intervention other than simply publication in an academic journal, whether it's engaging potential utilizers, community health centers, health systems, social service agencies. So I think in some ways this is a marketing issue, and how you raise the prospect of global learning to the various parties that could implement it. I think the technical part is not so hard.
Great. Yes, absolutely agree. So thank you, Drs. Zief, Obalu, Deering, and Sugarman for excellent presentations. Thanks for keeping on time. And I will turn it over now to Dr. Kupfer.
Okay, so now we do the magic of thank you, first of all, to all the presenters and to Chandy for moderating that excellent panel. And now we will magically go into our Zoom rooms, breakout rooms, and discuss what we heard and add our own experiences. And the small groups will also discuss methods, the research, and the gaps that could form a research agenda for this area. So Aisha, take us away. Okay, do we have time for just some quick, let's see, what time is it? 9:27. We have a little bit of time for each facilitator to just give 1 or 2 points from their session. Chandy, does that work?
Sure.
Okay.
So maybe 2 minutes a person or something. There's not much time, like you said, but yeah, let's see. Rashmi was our facilitator. So Rashmi, do you want to briefly summarize what we discussed?
Sorry, I was looking at my email, looking for the notes from Kristen and trying to go. So Shandy,
Right.
you were speaking, right? Go ahead and say, highlight a few points from our session, and then I will try to pitch in if there is some time. I mean,
Okay,
I can say, let me just start with one thing which really struck to me, and which I think I did say during our breakout session, is we have wonderful partners. We heard from various projects and initiatives from the panelists, and we do need to have our partners in person on the table when we are having discussions and we are trying to look at the challenges and gaps and trying to come up with a research agenda. And I'll stop there.
Great. Yeah, that I think that was an important point that was emphasized yesterday and today as well. And we were fortunate in a group to have GHRI Kiplagat, who's from my university and on this in this session, and she gave some pointers about what has worked with IU and the collaborative nature of the AMPATH work that Deb and others have led with GHRI, and how in that model, Kenyan involvement helps lead projects forward, and they remain identified with leading and key partners in the project versus it being something that comes to the high-income country and then it's only high-income country collaborators doing the work. So maybe we'll have that as a summary of our session, and then let's see. I think Divi Rao was one of the other small group facilitators. Divi, do you want to say anything about your session?
Arina, can you please project those slides? Yeah, so basically this group was charged with discussing the methods to describe the methods and then share the experiences that they have faced. And so we were initially discussing about the different methods that were developed for the reciprocal innovation. And Dr. Harris expressed that he had adopted the technology that was developed at the Harvard and then implemented that one in LMICs, and then also brought back the knowledge from the LMICs to the UK. And it took quite a bit amount of time, but he was successfully able to implement that one. And also someone talked about the human-centered design approach to, for the adaptation and then transfer of the methodologies that were developed. And then one of the companies, IDEO, developed that methodology, and then they were successfully able to implement it back in the high-income countries. And so we also discussed about I think someone from the NIH has discussed about the pre and post funding assessment of the approaches, methods that are being implemented, and so have a protected time for the pre and post assessment so that we can have a better impact on the in future during the implementation. And we struggle a little bit about the overlap between the implementation science and then the reciprocal innovation methodologies, approaches, frameworks. And as I said again, there was a discussion about the upstream methods and then addressing particularly the decolonization issues. And so in terms of the challenges and barriers that they have faced, basically the unconscious bias and then how to address the unconscious bias, and also about the discussed about the design structure and implementation of evaluation at particularly at the community level. And as I said earlier, we had struggle in how this is different from the implementation science methods. So next slide, please. And again, same thing came in resistance and acceptance and uptake of these methods, the overlap with the implementation science, and then the need for the pre and post assessments that needs to be supported. And the discussed about the lack of understanding of the need for these approaches in the overall, and how we overcome the resistance is through engaging mostly the stakeholders, including the non-government organizations effectively, so that we can have better uptake of these methods. And also leveraging the objective and then other resources to implement the interventions. And then And so we had little time because we were switched off in 27 minutes instead of 30 minutes about discussing about the big gaps and needs. And if anybody wants to chime in and then say something about the big gaps and needs in the mental space, I would really appreciate that.
Great, thanks so much. We just have a couple minutes left for Janella Walker to talk about her group's discussion.
Hi, yes, I'll go. We have about a minute. So in general, one of the main feedback that came from our group was that, and Yolanda was talking about this, there are over 20 frameworks that she was looking at when we tasked with looking at the frameworks and what is needed around those. And so the general consensus was that within these frameworks that there's funding that is needed to test these current frameworks that we have, not necessarily having more frameworks. And and some of the other general thoughts is that the rate limiting step is not necessarily those frameworks since we have them and there's so many. And so really looking at what are the characteristics of an organization that are able to do this. And also, when we're looking at the concepts of dissemination, reciprocal innovation, how is it embedded in these organizations and how are they solving these problems? And one of the examples that stuck out, a few mentioned, is reminiscent of implementation science and how we have many frameworks and models. And one of those concepts was even looking at the hybrids and how even with their different hybrids, type 1, type 2, type 3, these, while there are several frameworks, models, researchers were mentioning that they use many in their work, they still give the ability to have some type of structure, even with looking at an overall idea of having these top 3 things for those different hybrids. And so that helped to provide at least some type of foundation. And perhaps this is something that can be used within reciprocal innovation and really looking at things as a continuum. And it just and that pushes to the point that Anna was making, that there's no single solution and great minds think differently. And one of the examples that was also specifically shared in our group was the Henry Ford Global Health Initiative and how they work and have the charge to do that. And are there ways to provide funding or even work with different organizations to help them establish these types of things where they're ready to receive this type of work? Or for reciprocal innovation, and be open to that, and how does that shift, or can that shift within their organization? And so just one last thing for bidirectionality, really the example that Kate was giving from Henry Ford is that there's value beyond replicating a specific project, and perhaps it's more looking at, are there core components from the projects that we use when we're looking at bidirectional learning and reciprocal innovation that we can utilize to say that we are doing this, even if it doesn't fit specifically in a specific definition of what we typically do for reciprocal innovation. So
thank you so much for that concise summary. Rashmi has also added some things, since we didn't really have enough time for each of the people to present on everything that was discussed, but great sessions. I'm going to turn it over to Jen Cates for the next session.
Great. Thanks, everyone. Thanks, Chandy. Hi, I'm Jen Cates from KFF Kaiser Family Foundation, and I have the honor of moderating our last session for today, which is focused specifically on equity issues and laws that are affecting this work. And, I think, as we've all heard in the last day and a half already, these issues have come up already. This is constant kind of through line in all the remarks, but the idea of this panel is to really focus specifically on these issues and not just equity issues, but sort of the legal framework and laws that actually affect the research. Ultimately, I think a key theme that will come across, and I've heard from others in the other panels, is that this work has to be done thoughtfully, it has to be intentional. And so the panel that we're going to hear from now, the 4 expert practitioners, will focus, I think, a little bit more on the implementation side, on how do we do this work, who is involved in it, what is it? And so it'll be a nice natural extension of the conversation. Since I know that time is very tight, let's just go right to it. We're going to hear from Gary Aslanin from World Health Organization.
Okay.
Gary, please take it away.
Great, thanks. And let me start by saying what a great meeting so far. I've learned a lot already. So I work for WHO in a program called TDR, which is a research program. WHO obviously is a global public health agency. And in addition to that, we host a secretariat of an initiative called Essence on Health Research. It's a group of funders that came together over 12 or 13 years ago to look at how they can coordinate their efforts when it comes to research for health or research for health and development. So maybe I'll start by saying that this is one good practice kind of approach adopted by our members as a way of work, and I'll share kind of a link to our website for more information. And we've done this one with UK CDR, which is a UK equivalent of different development sciences, not just health, that have come together to try and coordinate things at the level of UK. So let me tell you, it's not easy at the level of one country or a global level. Next slide, please. So the issue here was not new, obviously equitable between North and South, how the process of developing these partnerships and relationships, this is clearly for any funder, and we have really wide range of funders. Obviously, NIH, through Fogarty and Linda, our fearless leader for so many years and involved. But we also have very different types of agencies that are development, that are foreign ministries. We have smaller foundations. We have funding councils in middle-income countries. So as with any other good practice document, the road into that good practice is just as important as the destination, where the funding agencies learn from each other. And we had a task force, which was really that place to try and allow for that understanding to come out of it. And this is really good example of with cases, etc., where you know, some of the research if done in equitable way, or some of the new evidence that comes out of that can be really used both in both countries, or in countries where reciprocally who are involved in that process. And of course, we engage institutions and research teams in various countries. Next slide, please. So we had a survey and we translated the document already into French. Similarly, we have other good practice documents that are in other languages, because we here are dealing with really diverse group of countries and stakeholders. And we have learning case studies. And UK CDR also has a resource hub that came up with that. Again, the idea here is this is not a treaty or a legal obligation of funding agencies. It's the document that created with their engagement, but then also has the soft power of changing some of the attitudes or approaches. But there are some other issues that are coming out that are more around the research management, etc. I'll come to that in a second. Next, please. So the concept of this is the issue of equity, and also in terms of what the impact of that research will be and where would that be. And we put the priorities from the countries where the impact is most needed or where the funding is put forward on top of this whole pyramid with really other components that are supporting. But that's overall where we came from in terms of equitable partnerships here. So next slide. It's a bit small here. You may not see everything there, but the idea here to show you or to show through this process of the work that some things really lead to a nice leafy tree, while others end up with some empty and naked branches. And really that's rooted in a lot of what you start doing in that partnership process. And if you really don't water those roots or don't really take care of, you'll end up on that on that other side rather than on the side where we want to end up with equitable partnerships, and of course with reciprocal innovation and reciprocal knowledge, and most importantly the application of that knowledge. Please take a look at the document when you have a chance. I've shared that. Obviously I can't do justice to it. So as next slide. In a way, our other documents are also organized, and we've actually received and continue receiving a lot of positive feedback with those who use it, that it's very user-friendly. So you basically go to the table of content, you look at the issue or approach, and you find, you know, an example from another funding agency. If you are a funding agency with what has happened there, no one has the long time to go into, you know, long publication, unfortunately. So, but that's distilled into this, and similarly here, the 4 approaches are organized that way. And first starts with research partnership ecosystem in terms of how the approach of the agency or the organizations involved needs to change, or how it's changing, etc. And of course, some of this is also think of global different players here, not just you know, North American or European, and everyone comes with a different attitude or approach to this. And this is something also we discuss a lot at maybe if you had a chance to hear about the Global Health Matters podcast that I host, some of the issues come out there in terms of how we decolonize or this whole area. I'll put a link for that there. So the approach 1, approach 2 is looking at strengthening research relationships and research systems, understanding of two-way learning. Here you go, really linked to some of the things mentioned so far. Relationships and supporting the systems around research. It's not just throwing monies at, you know, the PI and the lonely PI working in nowhere. So a lot of other things that come into that in terms of the relationships between the funding agency, the northern partner, southern partner, or the mix of South-South partnerships, etc. So again, there's an example and some recommendation that comes there in terms of how this can be done. I don't have the time, obviously, to go too much detail. I'm just afraid I'm going to be told 1 minute very soon. Approach 3. Budget and partnership building. For partnership building, this is an area also that keeps coming up in terms of the power and the resource imbalance and who manages funding and how that is managed, what are the rules, what can or can be done based on funding agencies' rules. To be honest, from what I understand, from what we've looked, in fact,
this is your 1 minute warning.
Right, NIH has really more progressive rules, in fact, compared to some other countries. So this is looking at that area. Number 4 approach is looking at the implementation processes and procedures to sustain the partnerships in terms of intellectual property issues, ethical issues, due diligence, reporting, and all of that being done in a more of a strengthened role of research management and research management professionals in institutions, especially in low and middle income countries, where this is really a relatively new area, relatively unfunded, undeveloped compared to some of the northern institutions, and that creates the imbalance. I think I have a final slide where, no, that was it.
I think so. Thank you. I think we'll just keep going. Thanks so much, Gary. That graphic with the tree, we got lots of positive comments and feedback on it in the chat. That was great.
Thank you.
Okay, we're next going to hear from, is it Ruth next or Matthew?
Matthew's next.
Yeah, so that, so Matthew Harris from the Imperial College will talk next, and particularly about his work on reverse innovation and other interventions. Matthew.
Oh, thanks so much, Jen. And can I just say, as everyone else has done, just how inspiring and you know, to be part of this webinar. I've read much of your work already, so it's a real honor to be participating alongside many of you today. So thank you for the invitation. And also just to say how nice it is to be able to talk about something different than the economic collapse of the United Kingdom and who's prime minister this week, you know, or the next, you know, so it makes a really nice change. So what I'm going to be talking about is I think probably some of the regulatory and legal barriers to adopting innovations from low-income countries into the UK context. So I'm going to be specifically focusing on UK, and then turn my head just very slightly also to some of the ethical or equity issues around that process, thinking in particular about what we are doing within international health partnerships in the UK. So these are collaborations between NHS, hospitals, and counterpart organizations in low-income countries, and how reciprocal innovation or reverse innovation, however you might call it, is being conceptualized and practiced in those contexts. The first thing I'd like to say is that you guys in the US seem to me to be streets ahead of what we're doing in the UK. I often find myself sort of shouting into the wind about the importance of reciprocal innovation, as you're calling it, reverse innovation, bidirectional learning, however you want to frame it. And it seems to me that in many, many localities around the US, you're already actually doing it. So that's really, really inspiring. But what we've been doing in Imperial College is, I suppose, it's sort of a nose to tail program of research, which is around identifying what are some of the innovation opportunities from low-income countries that we're aware of. And we're calling them frugal innovations, for want of a better word. So these are difficult to define, but frugal innovations that do more with less, arising from low-income countries. We sort of publish the rationale for the adoption of those innovations and try and find localities locally within the NHS to see who might adopt them. And then we also study a lot the sort of procedural challenges in that process. So issues around unconscious bias and decolonization and so forth. One of the main issues that I think are important to discuss around frugal innovation adoption is that frugal innovations tend to be sort of workaround solutions. They're improvisations. They're things that aren't necessarily patented or that are commercial offerings, or that have an enterprise behind them. They might just be actually a skill set that you might come across in a low resource setting, for example, a way of working. And that, I think, poses particular challenges in terms of adopting some of those, some of the learning into the UK. Not only, as has already been discussed, in terms of the demand aspect for that, but also in terms of the supply. It's difficult to actually translate that sort of thing. So I'm thinking of, for example, using mosquito net mesh for hernia repair. That's an improvisation that originated in India and then scaled throughout sub-Saharan Africa, but it's not patented, it's not commercially available. So that poses unique challenges for adopting it and getting into clinical practice in the UK. And there are other examples, such as the Saiba device, which is just a condom tied to a catheter used, originated in Bangladesh and also used throughout India, Southeast Asia, and Sub-Saharan Africa to prevent postpartum hemorrhage. Again, that's an improvisation using the resources around you. So how do you bring something like that sort of ingenuity into the NHS? And we really struggle with it, in part because there's no mechanism to do so. We have a very rigid regulatory system that makes it very difficult for clinicians to just improvise. You will have heard of NICE, the National Institute for Clinical Excellence, which essentially is the authority that mandates what technologies can or can't be used within the NHS. And they're very clear that unless a technology has gone through particular regulatory approvals from the MHRA or NICE, or has a health technology assessment that proves its cost effectiveness, clinicians in the NHS can't use it. But there's a slightly perverse scenario, because private clinicians, so those that are not practicing within the public system of the NHS, can do whatever they want. So there's a slightly perverse incentive, I think, within the NHS, which is publicly funded, free at point of use, resourced through taxpayer funding, where we end up actually sometimes, there are many instances of this, using really expensive alternatives to the frugal innovations that actually private practitioners can actually use from low-income countries. So that's a bit of an interesting regulatory hurdle. There have been some interesting developments recently within NICE to fast-track regulation of sort of medicines and things like that, or innovative new pharmaceuticals, for example, or repurposing pharmaceuticals for another purpose. But we're not really frequently talking about medicines or drugs when we're talking about reciprocal innovation. We're often talking about technologies or ways of working. So that doesn't really help us very much. There was one opportunity back in 2014 that looked promising, that would allow clinicians the freedom to innovate locally, which is in the context of palliative care, and something called the Medical Innovation Bill actually reached the House of Lords, which is like our Senate, I suppose, in the UK. But had got stuck there in 2014, and it would have allowed clinicians, in the context of end-of-life care, to actually try almost anything if nothing else had worked. And that, in some senses, is at the margins where we're operating in terms of how clinicians have freedom to practice. But that's got stuck, and so we're no further in that regard. I'm just going to turn my head now to the idea of reciprocity, and it's something that you might have actually talked about already yesterday, so forgive me if there's duplication here. But we do a lot of work with an organization called the Tropical Health Education Trust, which manages the international health partnerships I mentioned earlier. And there's a lot of talk around bidirectional learning, mutual benefit, reciprocity within those partnerships. But what we're finding is that those partnerships are still very much grounded in international development and assistance and providing health services overseas. And so there's a layering of narratives of reciprocity on top of that existing work. And it becomes quite interesting to see how the language is being used and abused, or manipulated, if you like, in order to accommodate narratives of reciprocity without actually changing anything. So what we're seeing is, in terms of mutual learning, for example, what we see is that both sides talk about learning, they talk about how much we've learned, but the learning that occurs is different for both sides. The learning that occurs for the low-income country partners tends to be of a technical nature, how to do things, translating innovative expertise and know-how from the West into those countries. But the learning that's happening on our side, if you like, from the UK NHS point of view, is soft skills. It's cultural learning, we might call cultural competencies. So learning about that country, learning about ourselves. But we're very rarely actually learning from that country. So there's a bit of a mismatch we're finding between the different types of learning. So when we talk about, perhaps it's an equity issue in terms of, are we thinking of learning in an equitable way within partnerships, we need to actually understand what is the learning that's actually happening on both sides. We very rarely see partnerships, in the UK at least, where the point of departure is a simple question: what problem do we have in the UK that you can help us with? And equally on the other side, what problem do we have in that country that the UK can help us with? Very, very rarely do we see those partnerships.
This is your 1 minute, sorry.
Thank you. From that point of departure. So that's on an equity issue. It's this idea of, are we conceptualizing learning in a similar sort of way within those partnerships? So I'm hearing already so many excellent things from previous speakers about how to ensure that that happens. And one of the things that we produced with the Tropical Health Education Trust, I think probably quite similar to Gary's resource, is a toolkit to enable participants of international health partnerships on the UK side to enter those partnerships from a point of departure that is equitable right from the get-go, and that includes asking questions, sometimes difficult ones, about their own unconscious biases. So I think I'll stop there, Jen. I tried to keep within time, and
that was great.
Absence of slides, but it was just a few points around the regulatory and legal aspects and some of the equity issues that we're seeing in the UK.
Thank you so much, Matthew. That was great. Okay, let's move to Ruth Berhe from the Friendship Bench. Ruth, take it away.
Okay, hi. Thank you so much for having me. I'm really honored and super interesting to hear all of you discussing all these important things. So I'm really an implementer at this point in time. And when Linda and I had our pre-discussion, I was also saying, there's not that much research in the international implementation that I'm trying to do. So can I have the next slide, please? So just super quickly about like Friendship Bench, we have this program where we're working with community health workers who are trained to deliver a simple program to help bridge the treatment gap for mental health issues, namely symptoms of depression and anxiety. And we do that in Zimbabwe. And we also have like a peer support group that has, the more I look at it now, has featured more and more income generation, because obviously in low and middle income countries such like Zimbabwe, poverty is a huge factor or like determinant of health in this context. So we're lucky enough, I mean, it took us a long time. We've been around like now for 16 years or something. We are having an MOU with the Ministry of Health. So we have the mandate to roll out nationwide in Zimbabwe. And we're doing this, as you can see, we were transitioning more from a very heavy research base to being an NGO now. And we're trying to get funding for this work because as you can imagine, the Ministry of Health in Zimbabwe does not have the money for this. So we're having actually a lot of philanthropy work, philanthropist money. And you can imagine that this in itself is a hectic job to find money. Next slide, please. Yeah, and so I just wanted to speak a little bit about coming from research money, which was literally money from the global north to us here in the global south. And as I was reading up in preparation for this, I was thinking, yep, there was all this that we need to pay attention to, like the equity of us here sitting in Zimbabwe, working from here. What exactly is the partnership? How are, for instance, papers published? Who's where? And someone mentioned earlier on the subconscious bias that I think we here in LAMIC have often towards the higher income countries. So we think we lack the skills and we need more input from the other person, which I see in some of my colleagues of rather being almost shy about their skills. And I would love to see that change and empower them more. Sometimes there are issues around workload. One thing that always comes up, and I don't know if other people work in low and middle income countries and have had this, that funding arrives really late, which means that basically projects are running, the clock is ticking, we're supposed to work, but the funding has not arrived. So we have colleagues and who work basically without being paid, with the promise the funding will come, the funding will come. Yeah, next slide, please. So basically this whole idea of who to work with, and now I'm going more into the implementation bit, is really, really important for us. So we are currently working I've trained people in Jordan and Vietnam and South Africa, USA, Canada, and soon in Colombia as well. And so we are actually a model that has made it to high income countries. Yet, unfortunately, this is not very like a research base at the moment, what I'm doing. So it's very much implementation. And basically what is up to me is I'm trying to sell the program to make money for the NGO Friendship Bench in Zimbabwe. So I have people approaching me, and this is so interesting because we were talking like, how am I deciding who to work with? And but when I look at, so earlier, Yolanda, you mentioned the group in Athens County in Ohio. We're actually working with them and are super excited. And I'm like an NGO kind of racialized minority, and now no reason are finding money somewhere. I mean, I'd love to see more collaboration and more incentives for everybody to choose a partner. Nevertheless, Virginia will talk about this a little bit more. It's like we, being the originators of the program, had to learn the hard way that there are legal implications if we work with someone, right? And that we have to sort of find funding to get legal advice on how to protect the brand. So get intellectual property rights, which all costs money, and often, well, that's definitely, I mean, I haven't seen that in research grants being put in, at least not the mental health arena. And it's also something we need to think about and learn about in future implementations. So can you go next, please? Okay, yeah, fine. Okay, so I would like to just describe a little bit how I devised the model. And I'm just, while I hear, I'm like, oh my, I'm also doing implementation science. I should be even more switched on this. So for me, it is like someone approaches me and says, I'd love to have the friendship.
You're breaking up just a little bit.
Like, what kind of reach do they have? What kind of, oh, sorry. I'm just going to turn off my video because that is not here. Sorry. I want to work. Are they ready to take this on? Who is
can someone turn off the video?
What kind of, sorry. Can you hear me?
That seems a little better. Try that.
Okay, sorry about that. Zimbabwe internet. So and what agreements are we getting between the organization, the partner organization, and us in Friendship Bench? And so I always try to carry out a theory of change workshop, and it's actually interesting because I'm having one tonight with a group in New York where I'm going to train next week. And what I noticed in these theory of change workshops that often the partner organization misses a lot of the stakeholders. So I have basically a lot of the, I mean, despite me saying, hey, bring as many stakeholders as you can, like your future users of your service, other people who support this or who could be barriers, gatekeepers. Often that's not the case. So I think we need to learn much more about that as well. I then have sort of devised a series of workshops to explain what this is really all about and what I can bring to the partner. And earlier on, some of you already spoke about core components and peripheral components. And of course, this is extremely important. If we lose core components, we're not doing the program anymore. And then it becomes tricky in terms of, can the partner then continue saying, we are doing, in our case, Friendship Bench, for instance, or would I then come in and say, well, you're doing something, but it's definitely not what we call Friendship Bench. So, yeah, let me just see. So talking about that one, I always like to bring in a research aspect for partners, but like I said, often a partner who is an NGO does not have the skills for research. So I wonder, I mean, listening to all of you and thinking maybe we need more support in creating those accompanying research projects when, for instance, I go somewhere and try with a partner to implement Friendship Bench, for instance. So I'd love to hear more about that, what I would have to do to get that. And okay, I'm getting a question. How do I determine core components? So for Friendship Bench, the one core component would be to have actually some kind of bench situation, even if it's a virtual bench, I don't mind anymore, but it's a one-on-one sort of talk situation between two people who are not professionals. I would even put that in, right? Like the counselor, as we call them, or in your setting, I would never call them the counselors. And that's actually another point that in Zimbabwe, Friendship Bench is kind of like the mental health program on the primary healthcare level, which would never fly, say, in the US, right? Like you do not need a community health worker who's basically untrained and gets a specific training to be the mental health service, because you have other services. So what I have learned from working with partners in US settings is that it's Friendship Bench becomes more of a signposter. So the community health workers who we train, or whoever they are more in charge of recognizing, helping, working around how someone can access services that are existent. Already, Lita, I like your question.
This is
Sometimes I'm not
one more
so
minute,
sure.
just to
One more
let you know.
minute, perfect. Yeah. I'm almost done anyway, so that's perfect. So I'm also not so sure anymore. Like, how can I protect the core competences there from the components, of the Friendship Bench. Next slide, please. Oh my goodness, what is this now? Okay, so obviously, yes, we come in with having evidence based from our trial here in Zimbabwe, but obviously there's much more need to trial this in other places. So there is a trial running in Vietnam. There was some in Malawi. We're trying to work more. Often then that as well stops after the trial. So we have to work much more. And I think people, NGOs, whoever, have to be supported to keep it running afterwards. And how, yeah, so I'm repeating this, I think. Next, please. That's probably okay. So yeah, like we said that earlier on, we want to learn from each other and to understand that experts, the partners are always experts for their settings, and I have to go in there with a lot of like learning curiosity, at the same time wanting that we as originating group are getting the recognition and the protection, and that we are being part of data sharing in the long run. And we want to work with long-term relationships. We feel that, as we said earlier on, this all grows, this changes in a setting. Everybody keeps learning what needs to be done, and so that's our plan. And then the next one is my last one. So thank you so much for your time and letting me speak here. Thanks.
Great, thank you so much, Ruth. That was great. And so now turning to our last speaker to round out the session, Virginia Rothorn from the University of Maryland, Baltimore, who will talk specifically about legal and regulatory barriers in this work. Virginia.
Thank you so much, Jen. And it's such an honor to come after Matthew and Ruth and Gary, who I cite in different ways. And thank you, Linda, for this wonderful opportunity to gather. You may be familiar with this graphic because Yolanda Obalu, who is my co-director for the Global Learning for Health Equity Network, spoke earlier and shared our framework. And our project is around helping health equity promoters bring interventions from outside the United States to the US. And part of supporting these health equity promoters is thinking about legal and regulatory barriers and how to work with them and meet those barriers. I know sometimes it's difficult to bring the law into a health setting, and I know the law is often used in an adversarial way, but I hope you'll see through this presentation that it can also be protective. So if you don't mind going to the next slide. I'm going to talk about a paper that I wrote. And just to prepare for that discussion, I think everyone on this call knows that the key health areas where other countries can offer solutions are around health worker skill substitution, decentralization of management, mobile phone or mHealth use, health financing. And I also do want to say that this recent article by Danelle Van Zyl Herman, I don't know if she's part of this talk, did remind us all that we shouldn't limit what we think of as global learning or reciprocal innovation to low-tech innovations. But whatever innovation we're talking about bringing to a high-income country, there is some legal or regulatory element to be aware of. And so just to put you in law school for about 30 seconds, the law or the adjective legal refers to binding legislation, which is passed by a state, local government, or emerging from courts. And regulations and guidance documents are adopted to implement the law. So when barriers can either emerge from actual law passed by our government or court, or the regulations that we live in to implement those laws. Next slide, please. So this paper that I wrote, it's called Legal and Regulatory Barriers to Reverse Innovation. I wrote it with my colleagues, Alex Plum and John Zervos. We spoke to 9 key informants who participated in the introduction of global healthcare approaches to the US health system. And they were all working without large corporate sponsors who can facilitate introduction to the market. So we weren't looking at those folks. And as Matthew discussed earlier, often when you talk about global learning or reciprocal innovation, we're not talking about drug development or medical device, but more healthcare and public health practices. So the legal barriers that these informants identified were fears around tort liability and standard of care, concerns around patient self-administered care, and the regulatory barriers they identified were around medical licensure, lack of reimbursement, task shifting, and scope of work challenges. And I'll bore into those a little more deeply in a second. But the surprise finding, which maybe isn't such a surprise given the US has such a reputation as being a litigious society, was the perceived legal and regulatory barriers were the biggest disincentive. Like, I am not even going to try to bring this innovation to a healthcare system or to the clinical setting because I am too scared about liability or the huge regulatory burden. Next slide, please. So just to talk a little bit about this standard of care example or issue that was brought up in my study. What is standard of care? So a healthcare provider can be sued if an act or omission during treatment deviates from the standard of care and causes injury to the patient. And the standard of care is set usually on a national standard of the average skills of that type of healthcare provider. So innovations by definition are deviations from the ordinary skills of a physician and may expose innovators to liability without protection that following the standard of care provides. So we know the standard of care obviously evolves over time, but very slowly. So an example where this, that someone brought, one of the key informants discussed was the use of visual inspection with acetic acid, VIA, which is, and this is what, I'm a lawyer, remember, using vinegar to detect the precursors of cervical cancer. So this is obviously a low-cost innovation that is could be defined as a frugal innovation, but it can't be patented or commercialized. So someone would have to bring it into the clinic and try to use it with no protection of the standard of care. So this technology, low-tech technology, has not been taken up in the United States because of fears of deviation from the standard of care and potential malpractice. So this is a significant barrier. Next slide, please. Another example that was brought up was this of telemedicine, and I know we've discussed it in some of the presentations. A chief executive officer of a Mexican telemedicine company was approached by a healthcare system in Los Angeles to see if those Mexican physicians could provide services to Spanish-speaking US residents, building upon the telemedicine services they already provide to Mexican citizens. So this service was designed to fill an existing gap of the limited number of Spanish-speaking physicians in the United States. And although the organization was ready to provide these services and had lined up the physicians, the licensure rules and reimbursement rules prohibited expansion into the US. In other words, because those Mexican physicians were not licensed in California, they could not provide this service. And so this didn't happen. Eventually, a contract was signed, and this Mexican telemedicine company became healthcare navigators in just connecting patients to services, but not providing any medical or clinical advice. Next slide, please. So an added concern or legal and regulatory issue I've been studying since that study was intellectual property issues. And if you go to the next slide, please, Irina. This is a very important issue. And I put what happens when you source an innovation like the Friendship Bench from outside the US, just to give credit to my friend Ruth.
And just one more minute.
One more minute, no
yeah.
problem. It is very, very difficult to work between countries on intellectual property issues. Our LMIC partners don't have the capacity to harness intellectual property laws or develop other models for sharing ownership. I know at my university and most high-income country universities have departments of lawyers that will help us harness the intellectual property, get into agreements, and that's often so that products can be commercialized. So something I'm working on with colleagues that I think is very important and I'd like to talk about further in this conversation is that we should all, when appropriate, be signing MOUs with our collaborators, and so that each party acknowledges the assets they're bringing to the partnership, that they enter into a written agreement around the authorship of publications, around the division of funds if a grant is achieved, and around branding, among other things. These are typically non-binding. International law is difficult, but it's very persuasive. It's almost like the soft law that Gary was talking about. If a disagreement arises in the future, that you have memorialized your commitment to work in an equitable relationship with your partner. So in the project that I'm working on now, we're developing a model MOU that can be used that I'd like to share with this group when it's done. But this is a solution that could at least go half the way, and at least helping partners understand that these types of agreements are important from an equitable perspective. And I think that's my last slide, but thank you very much. I'm looking forward to discussing more.
Great, thank you so much. That was terrific. Those four are exactly what we were hoping to get to with that session. Linda, I'm going to let you. Do we have time for questions, or do we really need to go into the breakouts?
I think our best bet is to go into the breakouts. I didn't see that many questions, so let's go into the breakouts.
Let's do it.
Okay, thanks.
So I think I think we have a very nice discussion, a lot about like the legal aspects of the frameworks, and how I could have a legal aspects of the frameworks for a GHRI, and how does your what we're going to be doing this. So there was an idea about, there was a discussion about the MOU could be a great idea to do that, and looking at the template that was discussed previously, and then there was a discussions about the pros and cons about it. One of the points saying that sometimes MOUs, as we probably know, some of us know, that it takes a long time. Sometimes it's going to be taking too long to start the process, and where or how can we be doing this, and how our funding agents could be asking that, and at what point of the application, pre-award, post-award, or how kind of different kinds of documentations that we can use that could be helpful to establish as a MOU. We also we're talking about perceived legal barriers, some that are greater than actual barriers, and talk about some of them. We also talk about, there was I think Matthew mentioned about a tool for looking for buyers in partnerships, and helping researchers and people to be aware of the bias. That something could be helpful to share with the community, and also we are thinking about how to ensure that partners institutions are treated equitably, and how NIH and other funding agents could be having a say on their calls, because even if some requirements that we can do, and suggesting language about equity and reciprocal learning or reciprocal innovation could be a way that the field could be thinking about it more. And there was a discussion about patenting frequently goes to high income countries. So something that is from a low, coming from a low middle country, and there was not patent. And then if that's going to be bringing to a high income country, how is the legal aspect if then they want to be patent? So is there something on the documentations that could be also be discussed and talk about it? And also something, one of the points that was building in something that allows low-income countries to plan for their interventions for sustainability. As an example, what happens to the French bench example, and one of the ways of doing is like charging for fee, but for countries who could pay for it, and then for those who could not, would be something that be more flexible. So there was a discussion how to be becoming this sustainable as it moves around. I will open for our other groups here to see if they members if would like to add something else. Something that I missed? No.
Well, I want to say that my group was a very interesting conversation. This is Miguel. Miguel was from the NCI. My group was a very interesting conversation, and we talk a lot about that this is a very complex problem to bring innovation from low and middle income countries to the high income countries. And it's not just legal issues. So there are also ethical and maybe cultural issues, in addition to the technical issues that problem causes. So for example, we talk about the example mentioned from the acetic acid to detect cervical cancer. And one of the members said, but the problem is they have a very low sensitivity, right? So basically, if you have have better tests, a little more expensive in America, so why don't you use those? So that brings the ethical issue. Even if you don't have the legal issue, like what happened in UK, right, where Matthew was mentioning about this very particular issue where the private practice can use something that the public practice cannot use it. So there is no legal issue, but there is an ethical issue now. So even, and you have medical association, even if I want to use that, so it's ethically used. So what is the ethical issue that will impel to translate this, or no, not to translate, but to bring this innovation to our court, right? So the conclusion is we don't want to use a bad solution for affordability, right? So we don't want to kind of pay the price in the sensitivity because it's cheaper in this way. So become an ethical issue. That also something that maybe I didn't hear that you mentioned, that we mentioned what we can do about all this, right? So you mentioned the MIUs is a good idea. So we kind of think about this issue in different stages, right? In the United States, as a research program or as a research area, we have a lot more flexibility than the clinical people. So we can use stuff that other people they cannot use as a research use only, research purpose only, right? So, and in that case, using that flexibility, and in that case, we have to go with the IRBs and all of that, so we can create some type of data or some type of pilot that can be used to move to the next level that could be something in the community, right? So one of our speakers, I forgot the name, I think was Debra, I don't remember, sorry. It was mentioned about this, kind of a pilot that using this pilot in this community with very particular issue, then you can move to kind of move the power of the people, right? More the power of the government to try to change policy that can allow you to actually implement this in a larger scale, right? So the example that we mentioned about the physician in Mexico, they're trying to help people in California. That is a very good covering a big gap, but they cannot because they don't have license. But this is a problem basically impossible to solve. How they give the license? So, but they may be regulation. They may be, you know, if a power of the politicians, then in some way they can be flexible. And we cannot do anything now in this point. But if we start with a pilot and we move a little bit forward, right, then we can have the power of the people versus the power of the the power of the government. And the last thing that I want to mention is the area where we want to use this reciprocal innovation. We cannot grab the whole thing and say, oh, I'm trying to, anything that I try to make it reciprocal or equity in the high income country. So, but we can identify some areas, right? Was mentioned an area in palliative care, for example, was mentioned an area. Maybe the government will be more flexible if we have the power of the people to give more flexibility in that area. Something mentioned the counterfeit drugs, right? So the process that started in some low and middle income country to identify that is a big problem, and then they can be translated and was mentioned here that was mentioned that they can be used actually though. So if you identify an area, counterfeit drugs, for example, that's, oh yeah, I can translate, I can move that to equity here, or the palliative care. So the question could be, who would be the right partners to identify those areas? So that's kind of, we couldn't discuss that question. That was my next question for the group, but we couldn't discuss it.